my absolute pleasure to introduce Dr. Reema Bahri, who is a clinical biochemist and a HOD of clinical biochemistry and quality at Batra Hospital, New Delhi. She's formerly heading quality assurance of SRL National and International Labs, and also the HOD of biochemistry at Vimta Labs, Hyderabad. Through the last 21 plus years, she's had her great experience in lab operations, quality management systems, training a lot of staff under her, and then teaching, which has been her passion. She's also NABL assessor, NABH assessor, CAP inspector, certified trainer on ISO 1518 and 2012 by NBQP as well as QCI. She's been awarded as the 50 most impactful quality professional at the World Quality Congress at Mumbai. It's an absolute pleasure to all of us here as audience to listen to you on identifying of risks in medical laboratories. Over to you, ma'am, Dr. Reema.
Thank you, Dr. Jayalakshmi, for the kind introduction. Today, I would like to share my experience and my learnings, which I, as a quality person, as a lab person, have learned along my journey working in the lab, with my colleagues, with my team, with my co-workers, handling the day-to-day work. So I would like to share my experience with all of you, with with my staff, my colleagues, about what is the risk management. And Dr. Rana has made, in his first session, has really made the task very easy for me, laying down the basic concepts of, the risk identification and management, which is actually, truly speaking, a very, very difficult and a poorly understood concept. So this is a picture of my hospital where I work, the Batra Hospital, Batra Medical Hospital and Medical Research Center. It is one of the premier earliest tertiary care level hospital, 495 bedded, with 42 specialties, which provides quality and affordable healthcare to all sections of society. This is located in south part of the city, South Delhi. A lab is governed by a lot of processes, right from the patients and to the machines, equipment, staff, and the samples, they involve all the processes from pre-analytical, analytical, post-analytical phases. And because there are so many processes, therefore, there are so many sources. There are known sources and there are unknown sources. And worldwide, globally, they have been categorized into pre-analytical, analytical, post-analytical. Also, the amount they have been categorized as, most of the sources lie in the pre-analytical phase, about 60%, sometimes 70%, and which is the most difficult cause to handle, because the error happens much before the sample comes to the lab. And there are known causes for it, and so much is unknown still. And around 10 to 12% causes still happen in the analytical phase, and still about 20 to 30% errors happen in the post-analytical phase, which we all deal with. Now, in short, medical laboratory has all these errors, all these causes of errors. They lead the lab to a wide risk footprint. So what are these risks cause? What do the risks do? So these risks impact the patients, they impact the staff, they impact the clinical staff, they impact the institution as a whole, they impact the community, and they also impact the environment. So basically, medical lab, it has a wide risk footprint. So let us have a look at the definition of risk. So what is the meaning of this risk? So risk is essentially a potential for an error to occur that could lead to patient or staff harm. Now, Dr. Rana has nicely explained that it can be estimated through a combination of probability of occurrence of harm and severity. And he has nicely explained that, he has rightly said that ISO 15189 talks very, very little about the risk management, and he has given a good list of standards. And also ISO Guide 51 and 14971 talks about the risk matrix. However, in our lab, for us, easy to understand is an IQC, we need to develop a good internal quality control program so that we have the right sample and in the pre-analytical phase coming for right analysis and the right for the right result to be given. Well, I will not talk about it much because I will leave it for Dr. Venkatesh and Dr. Rajkumar Vajpayee, who will be talking about the mitigation and the risk management in medical laboratories. Whereas I would like to talk about how to identify the risks in the lab. So there are various tools in the labs with which we can identify those risks. So the various tools which we can adopt to identify what are these risks in the lab and how to capture those and how to handle those. So first of all, a very common and a very easy to understand is, we can follow a fishbone diagram, and the name given is Ishikawa diagram, which is, as a tribute to its creator. So this simply helps to identify helps in the root cause analysis to identify, analyze, and improve the quality issues. So it talks about basically it's a cause and effect relationship. It talks about all the potential sources of failure, right from the specimen to the test system to environment, whether it is due to temperature, humidity, or any deficiencies in the competency training of the staff or the reagent problems, which can lead to the potential failures. So it is very important to capture all these causes, look at all these causes whenever any error is happen, or rather I would say likely to happen. So in short, risk assessment is something which we need to do, which we need to study much before the error happens. So we should not wait for the error to happen. We need to lay down robust processes in the lab. We need to identify everything, the quality controls. So basically, it's more of a preventive action. We don't have to wait for the error to happen. Rather, we need to have ideally a perfect sample and perfect reagents, the operators trained, the measuring systems should be calibrated, and the environment of the lab should be dust-free, temperature, humidity controlled, and everything in order so that we have identified all the potential hazards. Otherwise, all the causes, any of the causes could lead to incorrect test results. So Ishikawa diagram and simple fishbone analysis helps us to identify the risks. Another tool which we can use in our labs to identify Pareto analysis. Now, these are simple tools. Pareto analysis helps us follows the 80-20 rule. It is understood, it is commonly believed that most of the problems lie in 80% of the problems lie in 20% of causes. So in our labs, we can find out, we can kind of list down what are our major problems, because they will vary from lab to lab. So we can categorize them in the order of priority, in the order of most significant ones to the least significant ones, and we can list them and start monitoring them, and and then we can control them, because until we know what are the errors which are of most problematic in our lab, we cannot identify them. So Pareto analysis helps us to identify and control the errors. There are more tools given by various standards which are used to control the risks. So basically, risk management is risk identification tools are there to the FMEA analysis. So I would talk about few terms I want to just touch base upon, but I will also talk about how we can simply use them in medical laboratories. So let's have a look at these complicated terms. So there is failure mode effect analysis, the bottom-up analysis. So failure mode effect criticality analysis, FMECA. Then FRACAS, which is failure reporting and corrective action system analysis. And then fault tree analysis. So basically, these are the terms which, if you read the standards, we come across these terms, and these are the tools which are used by the manufacturers before the test system or the instrument is, or the assay is put up in the place, so that they identify all the errors which can happen, and it is given to the laboratory, and before it is implemented. And it is important, all the phases, pre-analytical, analytical, and post-analytical, are captured and well understood. So common difference or important difference between FRACAS and CAPA is that FRACAS is generally conducted by research and development department, whereas CAPA, which is a common term which we use in the operations department or also required by the regulatory bodies, and we are using in labs and in common terminology and day-to-day processes, so that is the basic difference between FRACAS and CAPA. And FRACAS also uses the matrix which we use in our labs. So in short, all these terminologies, all these tools which are used to design the robust assays and the robust processes and the robust equipments which we are using in the labs is to ensure that there is no failure, is to encompass all the risks involved in the lab, but still the failure occurs. And if there is even 1% chance of a failure, there is a catastrophe. So what we need to do is we need to ensure that this failure does not occur. That is the aim when we are here to report a patient sample. So what we do in our labs, we need to identify the complete process when we are in the lab at the start of the day, pre-analytical, analytical, and post-analytical. And I'm going to share with you in a very simple manner that what is okay and what is not okay. As Dr. Rana also shared with you and also answered some of the questions, about the risk matrix chart, I will talk to you about more practical examples just to also answer some of the questions here, that the risk can be evaluated against the criteria which she has already answered, and this criteria can be defined by the lab director, by yourself. You can design what criteria you want to give by way of probability and severity, right from improbable to the most catastrophic one. And the acceptability chart, the risk evaluation acceptability chart, is given by the standard ISO 14971. So I have captured some of the live examples to share with you what happens in day-to-day, working by my experience, working in different laboratories. So let's have a look at some of these interesting examples. So for example, hemolyzed samples. Now this is a very common example. All the labs in your journey also you would have experienced hemolyzed samples. So more so, we have experienced hemolyzed samples more coming from, inpatient departments rather than OP departments, or where the open system collection is happening. And still I have seen in medium and small size laboratories, or where I'm even going and doing assessments, I have observed that incidence of hemolyzed samples is more. So sample collection protocols is not followed. If we see sometimes, they push the samples through the bore of the needle, and then the RBCs, they due to the shear pressure, they lyse. And so we need to do a lot of trainings for the staff that they should allow the vacuum flow, free flow of the blood, and they should not push the blood through the needle, because it will definitely cause hemolysis. Also, sometimes there is a VIP syndrome. There is a VIP sample, they want to rush the sample to the lab, so they will shake the sample, and vigorous shaking causes hemolysis. So we tell them, whether it is a VIP sample, please be at ease, do not panic, do not rush, leave the sample there, let it allow, mix it properly, inversions, normal inversions, and just allow the sample, give the normal time to the sample to clot, and send the sample to the lab just in the normal way. So these are the a very common problem which we face with hemolysis. Then sometimes the samples get clotted. Again, the sample protocol is not followed, and sometimes the quantity is not sufficient. So these are common examples which are followed. Sometimes lipemic samples are there, or there are wrong collections. So these are very common examples which you would come across. Again, the pre-analytical causes are there. So when we see these kind of situations of hemolysis or fibrin mass or underfills or needle stick injuries, one simple answer to all the situations given in management review is shifting to the closed system. So that is the very good suggestion which the laboratory should give to the management, because that helps. It will help in reducing such errors, because even the CLSI and even the NABL document, it advises, it recommends the closed system collections. But still, we have observed due to cost cutting, sometimes the open system collection is being carried out, and then the lack of training and such issues leads to more problems like that. So the impact is on the patients when they have to be pricked again. So another example which I would like to share with you is in the ABG collection. So this is a very live example, a real example. So now blood gas collection, which is a very different sample. It is not from a venous, it is an arterial blood sample collection, a tedious collection, and a specialized technique is required. And patients are generally critical patients. They are not like routine OPD patients coming. So we did a gap analysis, and we did, we observed what was happening. So there were tuberculin syringes being used. There were 1 ml syringes which were being heparinized by liquid heparin. So we did a gap analysis and a gap audit, a third-party audit, and on routine process audits, we found that there was dilutional, if you can see in the picture, this is the syringe where there is a liquid heparin in that picture, and which the sample has been taken in the second picture, but it has not been mixed properly, and it is showing a clot. Then due to the this is a report of the same sample where the sodium is coming less than 100. So I will explain the reason, why. Because the liquid heparin has diluted so much, because it is a manually filled heparin, and definitely it is not a standardized technique because it's a manual filling. So it could be overfilled or underfilled, and the sodium has come as low as 100, which is not in a viable state. And sometimes we even receive the sample in a 5 ml syringe, the ABT sample. So such like examples we found, and we received clots. So such like situations. So once when I came across, when I joined, what happened was a clinician, my hospital clinician walked into my room, and with a great, empathetic situation was there. She spoke to me and told me that, what to do. She was under great stress. She told me that she faced a situation where the sodium was 118 in ABG. And she was worried because she had new residents, and she was worried that the residents sometimes, they may not be at such a time in the night duties, they may not inject a saline seeing such a report to the patient, and then the patient may not land up into, electrolyte imbalance. So how to handle this situation? So basically that moved us, and that gave us the idea to move the system and do this validation and do this process and change our syringes of practice of liquid heparin tuberculin syringes in which we were collecting our ABGs to the more sophisticated collection of pre-heparinized syringes. So what we did was ISO also recommends that the ideal collection device for arterial blood sampling is 1 to 3 ml self-filling plastic disposable syringe, which contains an appropriate anticoagulant, such as a lyophilized heparin. So ISO recommends that we should not, CLSI recommends that we should not use a liquid heparin. We should use a lyophilized heparin, because the choice of heparin should depend that the specific analytes which are to be determined and the method of analysis not impacted, because ordinary heparin can bind to ionized calcium and other electrolytes, and which often get analyzed with blood gases and pH, and special preparations of heparin are available which virtually eliminate the interference of heparin from binding of these electrolytes. So basically the liquid heparin, which causes interference due to dilutional effects, and also it has chelating effects. So lyophilized heparin is the answer. So this is advised, and that is why we did a validation where we compared the BD pre-heparinized syringes with 1 ml tuberculin syringes. We did inter-syringe comparison on the same analyzer, and from different ICUs, we took collections from the central lines and also compared with serum electrolytes, the same, and couple of samples we did. And we observed that there was more than 10% variation in sodium, which was due to dilutional effect of liquid heparin. There was falsely low calcium. We found erratic results in bicarbonate, in lactate, and in glucose values due to dilutional effects, and also the gases. There was spuriously low in tuberculin syringes, which was due to diffusion of gases from the thin wall of the syringes. So then we could present our data to the management for review, and which the management was convinced. And therefore, after that, we could change the system to the collection with the BD syringes, and we could eliminate all those risks where the patients, the critically ill patients, admitted in ICUs and CCUs were admitted, and we made a robust training plan and induction plan, and we made it as a regular exercise, and we still conduct it in our ICUs, wards, and ERs. And believe me, we had about even the huge clots we used to observe in ABG. Imagine ABG clot sample getting a repeat ABG prick. It's really painful for the patient. It's really troublesome for the patient also, and for the staff also to take another sample. And we had in the peak COVID times, we had reaching about 10 clots sometimes a day, because the workload was also very high. But today I'm happy to share that we have only almost nil or almost no clots. We are doing wonderful on ABGs, and this was due to the extensive validation and trainings which we have minimized the risk in ABG. However, another thing I want to share is that the COVID-19, it definitely posed more challenges because the PPE which we used, which was very difficult for blood collections. We observed sometimes there were different stories to hear during COVID. So once we received a case where the ABG came without, there was a different patient name, there was a different patient label on the sample, and the name on the TRF and on the ABG was different. So this is a discrepancy, wrong labeling. So we wanted to know why it is happening. And when we questioned the staff, and we rather than getting a little angry, we were more empathetic, because they were so overburdened, and there was huge patient influx in the wards and in the ICUs, and they were really, they agreed to the mistake due to carelessness and hurry, and they also admitted that they were facing a lot of difficulties, being too much in the PPE for long hours, but the patient was at risk. So we counseled the staff, and of course the document of incident reports were there. And once we received the ABG sample without label. So these are all the risks which happen in the lab. But we managed to report how in the lab we mitigate the risk is the person who brought the sample to us, we traced the sample, we followed the traceability of the sample, and to the ER, to the emergency department, and walked with the person who brought the sample and discussed with the emergency head, and then took the acknowledgement. And of course we ran the sample, because we can't keep the sample, and then we reported it. So another example which I would like to share, as a COVID, what happened during the COVID times was that, especially during the second wave, this happened, that there was a patient who was admitted, and it was the second day of her admission. So her CRP, when she was admitted outside, she came from an outside lab, her CRP value was 180. And in our hospital, when she admitted, suddenly her CRP came to 24. This was very surprising, because when the Delta check did not support this CRP value, and contrary to her other reports. And so when we questioned and we, traced that what happened. So we found that this patient was admitted in a room where there were 2 patients, and probably the sample of the another patient, the label of another patient was put on her Vacutainer. Now we also came to know how this happened. I wanted to know how this error has happened. So probably there was one staff who was taking the sample because she was in PPE. So there was another staff who was putting the label. So this all happened during COVID. So we all know that in COVID times, it was difficult for us also to go into the COVID wards and the COVID to check physically, but a detailed root cause analysis, a detailed investigation helped us to understand how the errors could happen. And then we discussed with the director of nursing and the sister in charge, the wards in charge, to, we used to have those stringent meetings and, continuous discussions to how to prevent these errors from repeat errors being happening, because these errors did happen, but how to minimize those errors was the whole question, because ultimately the idea was to minimize the risk. So that is the objective of the risk identification and management. So finally, we took a fresh sample, and the repeat value of CRP was 380, which was correlating with the patient's condition and which was reported. Now, another pre-analytical error which we come across sometimes is, which is a case where potassium value came 7.6, phosphorus was 8.2, and calcium was 8. Now, this was not acceptable to the clinician, because whenever the value is critical, we call the clinician before uploading the result. And the clinician said this is not acceptable. So we wanted to know what has happened. There was no labeling error. There was no, the sample was run with the barcode. There was no analytical error. There was absolutely perfect sample. There was no hemolysis, absolutely perfect sample. We could not find any random error, and all the causes, all the possible causes of analysis, pre-analytical, were ruled out. So we wanted to really know what was the possible cause. On a detailed investigation, we found that, and this patient was not even on the drip. So on a detailed investigation, we found that probably this patient was tied the tourniquet for a little long. Now, this is a case of pseudo hyperkalemia. So what happens is, if the tourniquet is tied too long and if it is tied too tight, what happens? There is a local cause of hemolysis, and sometimes this raises the potassium. We have come across such cases occasionally, and they do happen once or twice in a month, and for us, once it happened in one of our known doctors who gives a sample for routine checkup. So he was surprised to know such a high value of potassium. Even I was surprised, how come you got high potassium? So because he gives a sample for his blood sugar testing. So this was the cause of high potassium, and a repeat sample with a trained phlebotomist gave the normal potassium 4.6. So we did a preventive action of training the nursing staff and educating them about the importance of tourniquet application and the proper techniques. So regular robust training program is implemented to minimize such errors. So another example, sometimes we do get in the labs is, erroneous results, spurious results. A drip site sample collection. What happens? Potassium 10, calcium 2. This is shocking. This is really surprising. We don't even need to call the clinician. We just call the staff and find out. Now, because we are so tuned now that we suspect there is an IV drip collection. So in this patient, there was a suspected KCl mix. The patient was on a drip. So we halted the result on our own and we mitigated the risk. We asked for a fresh sample, and the potassium reported was 4.6, which was correlating and fine. Similarly, another example, sodium more than 200, and this and the ALP was 5. Now, this was an IT error. Now, in our setting, there's one process where we sometimes get an IT, this is an error related to, there's a process where sometimes there is a right kind of a click which needs to be done for a selection of the glucose vial. selection of the serum vial. So otherwise, what happens, the sample gets collected from the glucose vial. So probably that step is a manual step. So that step was missed. So what happened that the sample got picked up from the glucose vial. So naturally, if it gets picked up from the glucose vial, which has sodium fluoride, the sodium shot up to more than 200, and ALP was low because there was a chelation due to EDTA. So of course, this was not acceptable, and we could catch it ourselves, and the result was halted, and we reported with a fresh sample. So sometimes such pre-analytical errors happen, and where there are saline mix-ups, and we do call the wards and we ask for repeat samples, and we know that they are probable. So that's why we've given a score of 4 for us. Probability 4 means which is once per month, and that's why it is the score goes criticality as 8 for us, which we keep monitoring. Now, some of the examples I'll take as interesting examples in the analytical phase. Now, so this is a case where there were multiple frequent quality control failures, random errors, 1 to 3 errors, 1 to 3S errors, and observed in multiple analytes, especially in total preen, albumin, calcium, and the instrument also gave a flag. The equipment also gives a flag, and there were aspiration errors. So when we observed closely, the operator, in fact, the operator is the right person. He is the best person to give examples, to give the inputs on the random errors. Random errors are the most difficult to catch. I always tell in my trainings, they are the most difficult to catch, and the best person to give inputs on random errors is the operator. Because we, as the authorized signatories or the HODs, we are the last persons to do a retrospective analysis, but the operator is the best person to give inputs on the errors which happen on the spot. So this is a case of the aspiration error which happened at the equipment where the equipment was actually sipping not the sample but gel admixture. So what happened that during centrifugation, we were using the serum separator tubes of a specific lot in BD, in a Vacutainer lot, and during centrifugation, probably the gel was getting melted and it was getting mixed with serum. And the instrument, of course, it sips everything, what is liquid. So it started sipping the gel admixture, and we observed, when we closely saw, we observed that there was gel admixture in samples. This is a picture where there is a gel, where we can see, the gels, globules in the serum, and this is a gel sticking to the probe, sample probe. So our CAPA was to change the lot of the BD Vacutainer, raise the complaint with the company, to change the probe, to change do the entire equipment maintenance, and also to change the speed of centrifugation, which was revised basis on the new lot. So all that extensive CAPA was taken because the thorough review of the LJ and the frequent QC failures was done, and the entire robust corrective actions were taken and put into place. We changed the entire lots. They were raised, incident reports were raised. And so until this problem was resolved, there was close monitoring, and more stringent monitoring was done. So this is a classical example of what errors can happen and the risks involved in the analytical phase. But we did all these checks at the quality control levels only, and until the QC was passed, we did not run the samples. And our instrument was also robust to give us the check on the aspiration errors, and until each sample reported clear, it did not give a go ahead. So that is the beauty we have with the analyzer. So now another example of a classic example I would like to share, about analytical error was that there was a remote possibility, but we did face this error once in a lifetime kind of a situation, which can happen in a laboratory. Now this is a example which, there was once water, there is a pre-feed water which goes to the filtration, RO filtration, to the wet chemistry analyzers. And once there was a poor feed water quality fed, so that the filters could also not take care of it, and the post-filter TDS was very high. Generally, it should be low, less than 1, but here it was so high, it was more than 7, and that it led to a very bad quality of water in the system, and it reported multiple QC failures. And one report of the patient went wrong, and so for us, we had to review all the reports of the patients, and fortunately all the reports were fine, and only one, because the moment that error happened, it was all the work was halted, and only one report, because that was a Sunday and there were less work, and only since that event happened, it was informed, and only one report which went wrong was recalled, amended, fresh report issued. And as a preventive action, as a corrective action, as a preventive action, like Dr. Rana rightly said, that what we need to do is we need to not forget for the next month, but we need to think, we need to put actions into place so that it never happens in the future. That is called, not immediate correction, but also corrective action, and also, we need to put preventive actions in place. So we did a robust planning and a system change in the system, in the pipeline, so that this situation never ever happens. So we have to lay down such a matrix. We have to put our think tanks so that we do not face such a problem, So something can happen. These are unknown causes, we can't even think of such errors happening in the labs, but they can happen. And if they happen, we should ensure that they never happen again. So that is a learning we have to take out of every failure which happens. So another example, a good example is, so once our technician enthusiastically reported a critical value of calcium as 17.5. And to my surprise, I was like, what? Calcium 17.5? Looks like a little weird to me, because I've got the experience of calcium 14 and 15, and I wanted to check. So I went to the machine and saw the flag. It had a flag. So I asked my operator, boy, did you see there was a flag? And to my surprise, he had missed. He had just returned from his marriage honeymoon, and I soon realized that he was still there. He was really physically not, mentally not there. So sometimes they miss those critical flags which are there in the raw data, and they do not see those flags. And so this was actually, there was a fibrin which was in the machine, which was in the sample, which was a very slight thin fibrin which was picked, and that is why it gave an erroneous result. The instrument did give a flag, but it was missed by the operator. Again, a random error, which gave a wrong result. So we have to ensure that these errors do not happen. And if it happens, we have to train our staff, retrain our staff. Of course, the immediate corrective action is recall of report and issue the correct report, rerun, and but we have to also mitigate the risk by way of preventive action and ensure that these do not occur at all. So sometimes, yes, post-analytical errors also happen. We take care of pre-analytical, which is most difficult, analytical, but sometimes in spite of that, there are post-analytical errors also, which occur in the labs. So and especially when there are manual typing of reports. We do try to ensure that all the reports are interfaced, but whenever there are manual intervention, it is likely to error. So example, a report getting type B12, for example, 21.2 was wrongly typed, and the correct report was later released by way of amendment. And a wrongly typed report of A1C.34 was later retyped. And sometimes the comments are not released. So these were the few examples on the pre-analytical, analytical, post-analytical errors and the risks to the patients which can happen due to the errors. Now, sometimes in labs, there are some things which are actually not failures, but they can cause risk, they can cause advantage, or they can cause, let's have a look what are and what are not failures. So some failures occur. So some failures occur at interfaces between clinical labs and the clinicians. So sometimes the clinicians makes an incorrect medical decision, or they can even benefit from better information provided in the labs, and thus the errors can be minimized. So we had a case of a male patient. We still have, actually. This patient visits us regularly to the dialysis unit. This patient is of chronic kidney disease, whose creatinine oscillates between 4, 6, and so he's on dialysis. And so he was on a checkup where his vitamin D was low, and we tested his IPTH. Shockingly, his PTH went more than, it was more than the analytical measurement range. And when we diluted the sample, his PTH reported was more than 5,000. It came very, very high. So we, of course, left an advisory because there was a need for further evaluation to rule out the causes for such a high PTH for tumor. And a candidate for surgical parathyroidectomy, but we are still trying to convince this patient. So sometimes the labs can also, help the clinicians on, from patient harm, and, ensuring that the patients who are at risk, in helping the clinicians from the risk involved in their lives. And there was another case where we got the pancreatic juice for analysis of CEA and CA 19.9 and amylase, where all the values, where he had a high suspicion for very high values, our gastro surgeon. And surprisingly, the CA value was less than 0.5, the calcium 19.9 also reported less than 2, and amylase was just 3 in pancreatic fluid. So he was like, what is the diagnosis? Because he suspected pseudocyst, mucinocyst, and maybe pancreatitis, and very high values. But so the diagnosis given by the lab was, which helped him by way of exclusion, was a simple hydrated cyst, because everything came negative. So sometimes the labs are also in a helpful, and now fortunately in the last 10 years, the significance and the importance of evidence-based medicine has really helped is helping the clinicians and also the laboratories to arrive at a work in conjunction, hand to hand with clinicians, and for the benefit of the patients. So in the labs, generally, there is a lot of panic around, how to develop IQCP. And I'm sure my esteemed, panelists will talk more about it. Whereas there is a lot to learn about IQCP from CLIA and from the risks, the QC frequencies, metrics, and everything. And the quality assurance systems, thanks to all those which have evolved starting from 1950s till date. And we are still in the process of, lot to learn is there, and we are still in the process of learning and evolving.
There are a few questions that's been raised by the participants, quite a few of them. I would just take few, which is Dr. Sunita Deshmukh has asked, is preventive action and risk assessment same?
So in ISO 15189, the clauses are different. So actually risk identification comes much before the preventive action also. It's something which should never happen. We need to identify something which should never happen.
Very
but
true.
What we are actually doing is, we are doing more at an operational level. We are actually doing the last step, we are doing more of a corrective action and a preventive action. Preventive action comes after the error has happened. So preventive action is something once the error has happened, then we do immediate correction. Then we do a corrective action so that that error does not repeat. And then we put a preventive action so that such error, the occurrence of such error is absolutely minimized. However, risk management and before that risk identification is something that we identify the risk so that it never takes place. So we need to identify, like in the fishbone diagram, like we need to put the QCs in place, we need to put the reagents, we need to use such Six Sigma reagents, we need to have the quality controls, we need to have the calibrations, so that we do not have those failures. So risk management is very different from preventive action.
Very true. Thank you very much for that. And Dr. Abba has asked what is the criteria for identifying phi number? What is the basis for phi number as given to probability? And also, what is the way that you score, probability and severity? What is the basis for these scores?
So actually these can be designed, as I mentioned, and also Dr. Rana has said in his presentation, that they can be designed by the lab. In our lab we follow frequent as 5, and we could take improbable as 1, but it is the choice of the lab, director. So you could think what you want to put in the lab. You could put improbable once in lifetime of a measuring system as improbable, and once in a month as 5, so like that you could scale, based upon the frequency. Yeah.
Okay, so there would be differences in different laboratories.
Yes.
You have to just standardize in your own system.
You can, yeah.
Exactly, right. So Dr. Aarti has another question. How can we define the border between the risks from daily non-conformities raised or errors occurred?
So a very good question. Thank you for that. So this, I always say that every failure or every error is actually a teaching experience. It's a learning experience. So it is a good idea to capture the errors. So whenever any error happens, there is a problem. So it's a saying that every failure is a stepping stone to success. So if we take that as an opportunity, we can capture those data and we can start listing down and then start categorizing them and then start identifying what are our major problems. So first of all, it is okay to have errors. There is no need to get stressed about it. Let us identify all the errors we have. I'm bad, it is okay. I'm very bad, it is fine. I'm worse, it is fine. Doesn't matter. This is my worst. From here on, I will only improve myself. So first of all, it is good to accept all my errors. I will list down, I will write my errors, my problems. Then we can categorize our errors. And from the categorization, like I showed, we can have the Pareto charts. We can list down the errors from the most probable causes in the laboratory to the least probable one. And we can attribute those causes the level of significance, and then we can start monitoring them. Easy way is month on month, because week on week and day to day is very difficult and impractical. Day just finishes and week also passes very soon, like a roster.
True.
So a month on month generally works best for everyone. Probably that is why the global standard also gives a monthly quality indicators. It's the the practices which are laid down, easy to adopt. So I think that's good enough to go.
Yeah, fantastic. Actually, another question raised by anonymous attendee is very similar in the same lines, but instead of the NC or an error, just mentioned as an incident. So do we need to maintain details of incidents in laboratory? And if yes, what type of incident should you report in the laboratory?
It's very important to document. It is very important to document the incidents and incident report. So it is also a requirement of ISO 15189. So all the errors, and because whatever is not done is not documented, is not done. So it is important to write down in your daily non-conformance register or your incident log or whatever, as a part of your hospital CAPA or NABH program or NABL, whatever system you are following, that's purely a choice. But it is important to document the incident, because until you document, you will not remember 2 months later, 3 months later. It is very difficult to capture that data in your head, and also the stress about it. So once you capture it, it is easy to control it, identify, monitor, control, measure, reduce. So that is the, PDCA cycle.
Yeah. Excellent. Yeah. Why is that the total protein was always giving an issue in the scenarios that you had described?
No, because it was a gel. This is again a gel and mixture, as I had mentioned, and so that was the error because it's a protein based. Probably that's why it gave the error in the protein only and not another chemistry. So every chemistry has a different chemical reaction.
That's true.
And the biochemical reactions. So probably that is why the protein gave an error, because it was gel is it interferes with the analysis. Yeah.
Yeah, I think we've done with almost all. If there are more questions, thank you very much for an excellent presentation. And